Can you all hear me without the microphone? I like to wander around, so if that's okay. And does this clicker work? It should be allowed a equitable sharing of those resources. So let's see if the video works. Cool.
There's one view of us as biological creatures, that we are determined by our genes, that what we see in our biology is somehow innately us because of who we were born to be. What that misses is that we grow up and develop. We grow up as children, we grow up as adults and continue. We interact constantly with the world in which we are engaged. That's the way in which our biology actually happens. We carry our history in our bodies. How could we not?
Living in America should be a ticket to good health. We have the highest gross national product in the world.
I'm very happy to finally have some of my cars in one location, some of them.
We spend $2 trillion per year on medical care. That's nearly half of all the health dollars spent in the world. But we've seen our statistics. We live shorter, often sicker lives than in any other industrialized country. We rank 30th in life expectancy.
Especially of economically developed countries, we are at the bottom of the list.
A higher percentage of our babies die in their first year of life than in Cuba, Slovenia, Estonia. How can this be? Is this just because 47 million of us have no health insurance?
Healthcare can deal with the diseases and illnesses, but a lack of healthcare is not the cause of illness and disease. It is like saying, since aspirin cures a fever, that the lack of aspirin must be the cause of the fever.
Or is it mostly because of our American diet and personal health behaviors?
Those behaviors themselves, in part, determined by economic status. And so our ability to avoid smoking and eat a healthy diet depends, in turn, on our access to income, education, and what we call the social determinants of health.
But wouldn't our genes trump social determinants of health?
Among twins who lived together until age 18, who basically grew up in the same households, so had at least a relatively similar exposure. If they diverged later in life, if one became professional and the other was working class, they ended up with different health status as adults. This is among identical twins.
Written into our bodies is a lifetime of experience, shaped by social conditions and policies that can determine who will be sicker, who will die sooner.
There are ways in which our society is organized that are bad for our health. And there's no doubt that we could reconfigure ourselves in ways that would benefit our health.
There are huge inequalities in the society. All this wealth is maldistributed.
Pet food, ice for the pets' water.
And I think that's in part why the US as a whole has relatively poor health amongst the rich countries, and why even the better off people are suffering. And we think that that is not inevitable.
So this continues to what you were talking about, but it's also putting now a different twist on what we started talking about earlier today. So why is it that we are sicker, and why are inequities still around? So the determinants of equity are everywhere, and they touch everything. So education is one, access to health is two, the built environment is three, the jobs employability is four, the parks and natural resources, affordable safe housing, and so forth. So none of these, except access to health care, has any direct link to health care services. So it is not, as the video said, we are not well or we're not healthy because we are healthy, or we are not healthy because we have a doctor. So the example about the aspirin and link it to fever. So this brings us now to switch from a concept of health to a concept of wellness, because physicians manage health, but we manage wellness and maintain wellness. And wellness is not only the lack of illness or the elimination of ailments. Wellness is more complex, and these are three definitions that have to deal with wellness. And those that are highlighted, it's a state of complete physical, mental, and social well-being. So yes, health is part of that physical, but then social well-being is very important. But then the more important one is achieving full potential. We do not talk about potential as a health status. So whether it is those girls at the school in Egypt, or whether, as you were talking to me offline, whether it's the political system that we grow up in, how is it adding to us achieving full potential? And by achieving full potential, how does that reflect on our state of wellness? And if we want to philosophize things even better, more, then we talk about the 8 dimensions of wellness. So the 8 dimensions of wellness are physical wellness, which is what we all know about. This is related to health, physical health. But then you have emotional wellness, and it's beyond mental health. Emotional wellness is the satisfaction that we have from living a well life. You have environmental wellness. It's the air we breathe, the water we drink, but it's also the house we live in. It's the neighborhood we are part of. And social wellness is the social fabric around us, and how are we connected to our surroundings socially. Intellectual wellness is the right to education, and that you are achieving your potential by challenging your mind intellectually and getting the education that you should get. And occupational wellness is not only getting a job, but getting a job that you deserve, and a job that provides for you, and a job that you enjoy. A job that makes you, and I don't know if such job exists, it makes you wake up in the morning and say, yay, I'm going to work. Maybe you're not there yet, but at least it is fulfillment of your role as a productive member of the society. Because if you are stuck in a job that you hate, or a job that is not meeting your potential, then that is a stress that is adding to your daily routine, and therefore you're not well. And of course, with that comes the financial wellness. And poverty is a stressor. If you need to worry about how to make ends meet and how to feed your children and how to pay the rent and how to make payments and all that, then that is another stressor. And lastly, it's the spiritual wellness. And by spiritual, we are not only talking about religion, but we're talking about the whole balance of existence. The Japanese have a saying that says, spirituality is a reason to wake up in the morning. Why do you wake up in the morning every day? There is hope, and that's why. So all those 8 dimensions together will lead someone into a complete sense of wellness. And any disruption in any of those 8, then that means someone is not well. And this is not only applied to individuals, but it's also applied to communities at large. And by that, we are now looking into something that's called the Social Progress Index. And the Social Progress Index is the capacity for a society to meet its basic human needs and to establish or to empower that society to provide a medium that is well for them to be well. So that concept in the past used to be looking at countries based on their GDP, their gross domestic product, and per capita. And in the past, the idea was that richer countries would have a better opportunity for their people to be well. The Social Progress Index have looked at it from a different point, and they looked at 133 countries, and they looked at how are we a country that has resources, so a country that ranks high per their GDP per capita, how are they channeling that money into the community itself, and how is it providing infrastructure for the community to survive and thrive and be able to be a conducive medium for its residents to practice health. So what was very surprising is that the top 10 countries had countries that have lower GDP per capita than some of those ranked below. So if you look at New Zealand, for example, that ranks 5, their GDP per capita is 32,000. But their Social Progress Index is 87% or 87 points. If you look at the United States, which ranks 16, their GDP per capita is higher than New Zealand, but their Social Progress Index is lower. Now, of course, there was no surprise that the very, very poor countries also had very low Social Progress Index, and they are still suffering. This is the double whammy, basically. But this is the interesting one, is the very high and the high, where there is now this aha moment where you're thinking, okay, why such a country that is so rich like the United States does not rank among the top 10? So let's look into what goes into the Social Progress Index. So this is a 3-pronged thing. So the Social Progress Index have the basic human needs, which we all agree these are basic needs that every society should have. Your nutrition and basic medical care, water and sanitation, shelter, and personal safety. These are the 4 essential things that make you well. Then you add to it the foundations of well-being, access to basic knowledge, access to information and communication, health and wellness, and ecosystem sustainability. But then this is where the key is. It's opportunity. So you have the basic human needs, and you have the foundations of well-being, but without opportunities, you are still lacking a very important piece of the puzzle. And you, by that opportunity, then it's personal rights, personal freedom and choice, tolerance and inclusion, and access to advanced education. There is nowhere in those four that says access to a good doctor. There is nowhere that says access to good drugs. There is nowhere that says access to good hospitals. This is the core of why that picture, equality and equity, is different. This is where a community that provides an opportunity to its residents is healthier than others. And I'm not going to bore you with the details, but again, if you want to expand on each one of those, then again, the opportunities you have, for example, tolerance for immigrants. This is a true thing that we're now experiencing, whether it is those immigrants that come from our neighboring borders here in the U.S., or whether the immigrants that are on the news and that are dying in the high seas, that are fleeing a civil war, or they're looking for better opportunities. So opportunity is the key. So let's look at another video.
The story of Kim Anderson, a successful Atlanta executive and lawyer, illustrates exactly what David and Collins are talking about. We know that a healthy lifestyle should lead to a healthy baby. Women who eat well, exercise, get prenatal care, avoid alcohol and drugs and cigarettes are more likely to have a good pregnancy. But one of the best predictors for a healthy pregnancy outcome is higher education.
This is a picture of me, May 1984, when I graduated from Columbia Law School. People think I'm living the American dream. A lawyer with 2 cars, 2.5 kids, the dog, the porch. A good husband, great family. I've always been lucky to have good health. Always ate well, exercised, never smoked.
So when we look at Anderson, a well-paid lawyer in good health, we would expect her newborn to be a healthy, full-term baby. It didn't turn out that way. Back in 1990, when she was pregnant with her first child, Kim went into labor 2.5 months early.
I just wanted to know at least that if she was born alive, that at least we had a fighting chance. I heard her cry, thank God. But she was so small. I mean, you could like hold her in the palm of your hand.
Kim's baby, Danielle, weighed only 2 pounds, 13 ounces when she was born. She joined the ranks of almost 300,000 low birth weight infants born in the U.S. that year. About 1 out of every 14, all of them at a high risk of dying before their first birthday.
I remember getting home and being in the bathroom, I fell apart. Because it's like I didn't get to take my baby home, I remember just sort of falling apart.
In the terminology of social scientists, Kim Anderson's family enjoys high socioeconomic status, which increases the odds for overall good health.
Persons who are higher in socioeconomic status, persons who have more income or more education or better jobs or more wealth, live longer and have fewer health problems than those who are lower in socioeconomic status.
Education, for example, predicts infant mortality for both black women and white women. And the more educated you are, the less likely you are to have a low birth weight baby, a preterm baby, or an infant death.
Women who are poorest and least educated are those whose babies are at greatest risk in any racial group. But the babies of African American mothers with higher education are still at greater risk than we'd expect. Infant mortality among white American women with a college degree or higher is about 4 deaths per 1,000 births. But among African American women with the same level of education, infant mortality is nearly 10 per 1,000 births, almost 3 times higher. In fact, African American mothers with a college degree worse birth outcomes than white mothers without a high school education.
Think about this. We're talking about African American doctors, lawyers, and business executives, and they still have a higher infant mortality rate than non-Hispanic white women who never went to high school in the first place.
As a mother, you're thinking, I did all the right things. They told me to take vitamins, I took vitamins. They told me to walk, they told me to eat vegetables, they told me not to drink, I didn't do all that. And why is my kid sitting there with these needles? And, so you feel real helpless. You really feel helpless.
So Doctors Collins and David asked themselves if the answer could possibly be genetic. It's well known that it can run in families. Is there something in the DNA of African American women that tends toward premature births regardless of education, prenatal care, or lifestyle? To answer the question, they created a study based on a simple assumption.
If there was such a thing as a prematurity gene and it came from Africa, then Africans should have more of it.
They compared newborns among 3 groups: African American women, African immigrants to the U.S., and U.S.-born white women.
It turns out that the Africans and the whites were about the same. The African Americans, on the other hand, had babies that weighed 8 or 9 ounces less than the other 2 groups.
In other words, African immigrants to the U.S. and white women born in the U.S. had similar pregnancy outcomes. So if there is any genetic predisposition for low birth weight babies, it's doubtful that it falls along what we call racial lines.
Yeah, she hadn't had any drop in her heart rate with these days.
It turns out that when African women immigrate to the U.S., it takes only 1 generation before their daughters are at risk of having premature babies at a significantly higher rate and with poorer birth outcomes.
Has her heart rate been in that range, over 180?
No, actually, it's been about 1.
So within 1 generation, women of African descent are doing poorly. This, to us, really suggests that something is driving this that's related to the social milieu that African American women live in throughout their entire life.
So it takes 1 generation to conform, and I don't know if this is a simulation or integration, but it's definitely done the bad way. 1 generation for those healthy mothers, their daughters would experience exactly what those that are born here, and the outcome of their daughters is going to be different. So switching a little bit to teenage pregnancy and intended or unintended pregnancies. Of course, you know the definition, but if you look at those women in Michigan that have an unintended pregnancy, then mostly they are black women, less than 18 years of age. They have less than a high school diploma. They're not married. They have no insurance, or they have underinsurance, which is Medicaid. This is the government subsidy program. And they are poor. So all these add to a choice, or maybe it's not a choice, but add to the risk of a teenage girl or someone to have an unwanted pregnancy. And if you look at the infant death, maternal death, preterm birth death, and very low birth weight among all races, then again, these are the highest from the 90s to the 2000 to 2007, all over. And as a country, the United States has the highest teen birth rate compared to other countries, similar to our, I guess, economical status. And these are the teenage birth rates, again, per ethnicity and race. And you can see, again, the blacks, Hispanics, American Indians are higher than the non-Hispanic whites. The same thing applies to diseases that affect the reproductive health of women, and especially young girls. So this is gonorrhea, and by race, you see the difference between whites and blacks. The same thing applies to new HIV infections, although the composition of the female populations, 2/3 of the female population in the US are whites, 2/3 of the female population have HIV are black. So again, the health outcomes are no longer a choice of what you are doing and what you are not doing. It is not, you're not healthy because you are not taking care of yourself. It is a combination of policies, your environment, the community you live in, that leads to risky behaviors, that interacts with clinical care, that affect your health outcomes. So there are a lot of things that we can do to reduce disparities and also to ensure a reproductive health and social justice. But let me stop here, and maybe we can have this as more a discussion, or if you have any questions. Yes. Yep. There is, I do a talk that is called Healthography. So it's health related to geography. And there is a lot of global data. This is not only us, but the reason I'm presenting it because of where we are in our setting. But for example, take the UK and take the City of London. You can also look at parcels or zip codes or regions in the City of London proper where women die more than men, or women live shorter than other women living elsewhere. So again, I think the concept is, and it is also something that we have in the Middle East and in North Africa. It is something that we have elsewhere. But because it is not well studied, then those disparities are not documented. But the concept is, again, opportunity. If you have the opportunities for people to be empowered, for communities to uplift themselves, then those disparities should not be as prominent. I am not denying that there is a self-behavior or self-responsibility as well. I mean, yes, you shouldn't be smoking, you shouldn't be drinking, you should exercise, you should eat healthy, but sometimes it's everything around you that adds to the choices you make. And sometimes your only choices are bad choices. It's both, but it's definitely measured by a scientific way. To some degree, but it'll be hard for me. I mean, as a physician, I might tell you whether you're well or not physically through tests and whatever. But probably it's hard for me to know if you're spiritually well. It's hard for me, well, I can look at your bank account and tell you if you're financially well. But yeah, it's the wellness concept, it's not only, I think it's more powerful when we look at it from a community setting. So what I do for a living, where I work, I am responsible for the health department. So public health is one of my duties. But earlier this year, I shifted from the health concept, which is, I mean, public health. Public health is sexually transmitted diseases, environmental health, immunizations, and blah, 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 which are great. But now I have two new programs, actually two new divisions under me. One is called social wellness, and one is called community wellness. So community wellness, I have made it now a goal for the health department to go to a neighborhood and change the neighborhood. And how do we change the neighborhood? You look at a neighborhood and you say, okay, you do not have complete streets. So complete streets are streets that allow you to walk, allow you to jog, allow you to bike, and also allows cars. But that concept is so alien, specifically where we are in Michigan, because we're heavy on the auto industry, then we do not have that. I was probably surprised to be asked several months ago to talk at the American Association of Architects. And I was probably the first doctor to address a group of architects sitting there, and I showed them why they are now responsible for a healthy community, not me. Because when you design, I gave a talk in Muscat, in Oman, earlier this year, and I wanted to use the Arab world data. So I wish it's on my laptop, I'll show it to you. But I looked at New Cairo. So New Cairo, I mean, you know Cairo, you have your streets and you walk and all that. But now, even in the Arab world, New Cairo and all those developments that are being advertised of complex communities, a gated community, those gated communities are going to transform the health of Egyptians towards the worse. Because you are now living in cul-de-sacs. You are going to, if you want to go buy milk, you need to get in your car and drive somewhere else to buy it because you are now isolated. And people think this is luxury. We have a villa. I guess dictatorship sometimes pays. I should go and tell them, no, you cannot do that. Yeah. But yeah, it's a whole different shift of how things should happen. One step at a time. Yes, sir.
Well, your talk is powerful, and I just wish the audience were politicians, but that's another story. I mean, because you speak of, the health opportunity of tolerance, and I'm saying that there are political answers because it appears that in some populations there's less tolerance,
Right.
political parties or wherever you look. But I can't wait to see what evidence will be shown for the health care access, where when you look at the Affordable Care Act, what difference it can make, but we're going to have to wait for that.
Yeah, the Affordable Care Act, of course, is a great step in the right direction. Not only because it allows access to health care, but there were components in the ACA that talked about prevention, that talked about the social determinants of health, that talked about community wellness and the community health centers. The beauty about community health centers is not only they are centers providing comprehensive primary care to those that need it, but it's for the ancillary services that a community health center can provide. We have a community, I run an FQHC in the city of Hamtramck. So the city of Hamtramck is in Detroit. It has 32 spoken languages. It has Bengalis, it has Yemenis, it has Polish, it has African Americans, it has every nationality that you find on earth, it is there. The school system literally has 32 languages. So it's very heavily immigrant-based. So our clinic in Hamtramck does not only provide regular clinical care, but it also is part of a bigger social fabric where we provide translation services, we provide immigration attorneys to help them with, we provide school dresses for young women to go to the prom. It's truly a community center. And this is the potential that a health center can transform a community rather than the big hospitals and the big powers. Federally qualified health center. So this is a clinic that should not turn anybody away. Anyone that walks through the door, and I know we have to wrap up. Anyone that walks through the door, whether they have the best insurance on earth or no insurance at all, should receive the same and exact clinical care regardless.